fusion here, so you have to use the PET as a guide. But again, we would always be on the conservative side here. We don't want to increase the volume. This is full-blown overlap of previous field. Can we switch to the lung window? So obviously you can see changes from the COPD in the previous field. You can see a lot of what seems like distal collapse. Don't mistake that. That is the tricky part usually. And again, the areas that we previously said, so the areas that had a lot of radiotherapy have a lot of changes. So again, don't mistake that. So again, Dr. Wael, if you go up and down, okay, and can we put the participants' contours? Okay, so yeah, go down, Dr. Wael. So I would say I'm very happy with these contours. All of the contours, I would say. So the overlap between the author contours, what we would consider as gold standard, there is no absolute gold standard. فيش حدا 100% صحيح. بس بصراحة الأوفرلاب كتير جميل، ونسبيا الكونتورز تبعتكم مش كبيرة، ومش مفوتة أماكن حقيقة يعني كثير بعيدة عن الواقع. يعني حتى الشخص اللي شوي طالع لفوق يعني it's not very far away from reality، ممكن طالع شوي زيادة عن اللزوم. بس بصراحة يعني جميل الكونتورز، لأنه الديستال كولابس، لو سمحتوا الصوت ورا، الديستال كولابس مش معلمينه، الأماكن اللي هي كان فيها راديو ثيرابي دوز ومش تيومر مش معلمينها، وهذا بصراحة يعني بيبين لنا إنه البير ريفيو بيشتغل. بس نغير لدكتور وائل للميدياستينم ويندو بعد إذنك. يعني بالعادة and Mika, what do you think, Mika? In previous courses we've always had a lot more discrepancy, and I wonder whether peer review has worked here. So هاي فائدة ال peer review. كمان مرة نطلع وننزل. يعني هلا this person who has contoured this soft tissue change going cranially, I would say is not necessarily wrong. What do you think, Dr. Ming? Because there is something there. It might not necessarily be from the tumor. But again, playing with the window level can help. So if you go down, Dr. Wael.
I think for CTV, there's a lot of personal judgment.
Definitely. And again, هذا بيصفي مرات بيكون في مكان انت متأكد منه 100%، مكان you're not 100% sure about. You can add it to the CTV if you're not 100% sure about in these cases. Window level can help a lot. Whether or not it's going into the vessel can also help a lot. But I would say well done. You know, you've done a fairly good job, and a lot of these contours would be considered clinically acceptable deviation of practice. Yes, Dr. Omesh.
A small query from my side. You said we utilize PET information to contour. So what sort of edge would you take on PET?
I mean, you can take obviously 40% max.
Max
I tend to use PET as a guide personally, but what about your practice in gynae and urology?
In gynae we have range between 35 to 40%
Okay.
of max,
Mhm.
but then others also use one value higher than the median or mean SU uptake in the normal muscle.
Okay.
Yeah, but I think there is no consensus.
There is no consensus. Okay, that's great. So for the purpose of time, what we will do now is I'll give you a little bit of teaching on organs at risk fairly quickly, and then we'll ask each group to do one organ at risk, and we'll have the other groups kind of comment on their work. Okay, so thank you very much, Dr. Wael. So احنا الاورجنز ات ريسك، انا هحكي لكم عن كل الاورجنز ات ريسك هلا، ولكن الاورجنز ات ريسك اللي هنركز عليهم هم بشكل اساسي هم الاسوفيجس والبروكسيمال برونكيال تري والبريكيال plexus، لانه ممكن هدول هم الاصعب، فهننقي الجروبس كل واحد يعمل one of them and then for the other case we're gonna switch, so you're gonna potentially have a go. So for today, quickly discussing the heart. Obviously, you know the heart is formed from a base, which is mainly the left atrium, the apex, mainly the left ventricle. There is different guidelines for contouring the heart. So usually the breast guidelines are different from the lung guidelines. There is also discrepancy, I would say, Dr. Meng, across the Atlantic. So in Europe, we tend to go to the superior aspect of the pulmonary artery as routine in lung cancer, while sometimes in the US, they tend to go to the point where the pulmonary trunk and the right pulmonary artery are seen as separate structures. You have to know the way in which your institution is doing it. You need to do it consistently, because it's important then if you want to re-audit your data and look at your outcomes, it is quite important that everybody's doing the same thing or similar. So again, for us, we generally would recommend to go to the cranial aspect of the pulmonary artery, so around here. And we are mainly following this UK isotoxic IMRT atlas, but then there are different atlases and different guidelines. The lower limit of the heart is sometimes a little bit difficult to see. I would always look at the coronal sequences, go back and forth in the coronal sequences, make sure that you capture the pericardium, because obviously pericarditis is one of the side effects that can happen. And one of the reasons why I think capturing that upper part or base of the heart is important is حاليا احنا عندنا evidence قوي انه the base of the heart is linked actually to worse outcomes, so higher dose to the base of the heart. And we have multiple fairly, I would say, low evidence, retrospective data sets showing this, but they have also shown the same thing from larger studies such as RTOG 0617. We in Manchester did a reanalysis of RTOG 0617, and it seems to show that the base of the heart, higher doses there are associated with worse outcomes. So it might be the area of the sinoatrial node. The conduction system of the heart is quite important, and that is typically present in the base. And so generally we would go to the top of the pulmonary trunk. Some people would exclude the superior vena cava if you have contrast. I wouldn't do that, because I think you have relatively important conduction apparatuses of the heart present there, and you also have important coronary arteries originating close to that site. And just make sure that you look at the coronal sequences. Now moving to the esophagus. So for the esophagus, we start our contour at the cricoid level, so the upper sphincter, and we go down to the gastroesophageal junction. We contour the esophagus as one structure. Obviously, you cannot tell the different layers of the wall of the esophagus, and we tend to use mediastinal window to do that. If you have a radical case, a fractionated radical case, you would do the entire esophagus. If you have an SBRT case, you can do 10 centimeters above and below where your PTV is. Bear in mind that there is indentations of the esophagus, so there's an indentation by the aorta, by the left bronchus, and the left atrium. And you can see this indentation here by the left bronchus. الشغلة اللي شوي مرات بتعقد الناس انه الاسوفيجس مرات بتشوفه contracted، يعني مسكر، ما في air column زي ما انتم شايفين هون، ومرات بتشوفه in a dilated state، في جواه air column. طبعا if it's in a dilated state it's much easier to see. And your knowledge، هلا معرفتك انه هو وين بيكون وامتى بيكون dilated او contracted بيفيد. يعني في بداية الثوركس الاسophagus is usually closed. هلا at the level of the carina the esophagus is usually open. بعد هيك من ال upper part of the heart لحد ال ventricles the esophagus is usually closed وبيكون كثير صعب انك تشوفه بالذات لو ما فيش عندك contrast. وبعد هيك لما تنزل تحت بيفتح الاسوفيجس بتقدر تشوف الاير كولوم بسهوله. ولما توصل للlower sphincter it is almost always closed. فمعرفتك بهاي المعلومات بتفيدك كثير انه تقدر تحدد. هلا المنطقه هاي usually esophagus شكله زي flat triangle فبتقدر انت تحدده عن طريق usually interpolation ما بين الكونتورز. هلا اذا مش ملاقيه يعني search for the air column so search when it's dilated it's usually very easy to see. اتاكدوا انت مدخل كل الثيكنس تبع الوول. والشيء اللي الناس كثير بيتلخبطوا فيه انه الازيجس فين بيلخبطوه على انه اسوفيجس. هاي الازيجس فين هو واضح جدا لما تكون انت معطي كونتراست زي هون. شوف واضح انه هذا فين وهذا هون الاسوفيجس. بس if you don't give contrast you can easily mistake it so you need to know the anatomy of the azygous vein. هلا we're gonna move on. But does anybody have any questions so far? Okay. So we're gonna move on to the PBT. هلا ال PBT احنا اليوم we're gonna talk about the proximal bronchial tree proper. But I just want you to make sure that you have your definitions correct. So different institutions have different definitions for central and ultracentral tumors. هدول مهمين بالنسبة لنا لأنه في بعض الحالات it is not very safe to do SBRT particularly for ultracentral tumors outside of a protocol outside of a clinical trial. فمهم انك تعرف الديفينيشنز مظبوط. ممكن تكون الديفينيشنز مش بس مبنية على البروكسيمال برونكيال تري ممكن تكون كمان مبنية على الفيسلز. الاي SLC central zone definition مبني على الهارت والبريكيال plexus والجريد فيسلز as well. فانتبه بس على الديفينيشن اللي انت يعني بتحكي عنه. هلا بدنا نحكي هون عن البي بي تي كونتورنج لانه هذا حنطلبه منكم انه تعملوه هلا. واحدة من الجروبس حتعمل البي بي تي وبصراحة هي حتكون الجروب ممكن الأصعب بالنسبة لهم. هلا احنا what we include the distal 2 centimeters of the trachea بالproximal bronchial tree. We include the carina, the right and left main stem bronchi. We include the bronchus intermedius, right middle lobe bronchus, lingular bronchus, will right and left lower lobe bronchi. And we stop the contour immediately at the site of the segmental bifurcation. So حورجيكم أنا هلا هذا الموضوع لأنه بصراحة في a little bit of tricks here وبدي إياكم تنتبهوا لأنه هي هاي usually a lot of people make some mistakes here. هلا أنت بالنسبة للرايت upper lobe bronchus okay it's usually simple. والرايت middle lobe bronchus is also usually simple. بس الرايت lower lobe bronchus a lot of people would stop prematurely. هلا أنت you need to see 3 segmental bronchi come off أو 3 bifurcations come off before you stop. هلا راح أورجيكم إياهم إن شاء الله بالتفصيل. بالنسبة للleft side المشكلة usually كمان هون بالرايت lower lobe bronchi إنه أنت you stop prematurely أو في بعض الناس they contour mistakenly هون زيادة عن اللزوم. يعني بس انتبه مشكلتك الأساسية بالرايت والليفت lower lobe bronchi والليفت upper lobe bronchi. هلا احنا عشان نحدد محل الكراينا لازم نستخدم الميدياستينال ويندو لأن احنا we want to see the cartilage. وأحسن طريقة إنه نحدد فيها محل الكراينا هي باستخدام الكورونال فيوز. بس دائما وأبدا لما نيجي نرسم الفول thickness of the wall we need to use both windows. شوف هون احنا لو رسمنا فقط on the lung window we would be underestimating the entire thickness of the wall which is pretty much captured better using the lung window. الشغلة الثانية مرات بتفيد انه تستعمل ال phases of the 4D scan. هلا احنا كل ال organs at risk we draw them on the average scan. انتوا طبعا بالحالة هاي تاعت ال radiation ما في عندكم الا بس one scan so you're gonna draw everything on that scan. بس usually شوف كيف ال different phases this is the same level and you can see quite clearly the bronchi here on one of the phases of the 4D scan but you cannot see it on the average scan. So yes, we draw on the average scan, but we can use the phases of the 4D to help us a little bit, to cheat. يغششونا محل التيومر. هلا شوفوا انا هون ورجيتكم. هلا انت لما تعرف الاناتومي راح كثير تستفيد. هلا انت هون بالرايت upper lobe bronchus، شوف احنا هون احنا عم نحكي هلا عن الرايت سايد. الرايت upper lobe bronchus بدك تشوف في عندك الابيكال segment, الposterior segment والanterior segment. So you keep on contouring till you reach the bifurcation. اوكي لحد هون. بعد هيك تنزل بال intermediate bronchus او البرونكس intermediate. بعد هيك بتشوف الرايت ميدل لوب برونكس. هلا الرايت ميدل لوب برونكس از ايزي لانه السيجمنتال بايفوركيشن اللي هم اللاترال والميديال يوجوالي بيطلعوا بنفس السلايس، فبتقدر تشوفها بشكل واضح. بتوقف هون عند هاي النقطة. هلا احنا حكينا التريك كلها بالرايت لور لوب. هلا الرايت لور لوب شو لازم تشوف؟ لازم تشوف السيجمنتال السوبيريور سيجمنت كم اوف، طلع هاي السوبيريور سيجمنت. بعدك لازم تشوف الميديال والانتيريور. هاي الميديال وهاي الانتيريور. قبل ما توقف، في ناس كثير بيوقفوا هون او هون، كله هذا prematurely. فهي التريك انك ضلك ماشي لهون. الشغله الثانيه اللي تنتبه عليها انه حقيقه الكاليبر هون مش زي هون. فما تيجي تحكي والله كثير صغر البرونكس فانا راح اوقف لانه صغر، لا هذا خطا. انت تضلك ماشي لحد ما تشوف الاناتومي تبعك الصحيح. هلا مرات ما بتقدرش تشوف الاناتومي، you kind of interpolate in your brain a little bit, but you have to see some of the anatomy. يعني superior segment usually very easy to see. هلا الميديال sometimes not very easy, بس anterior you can see. So if you see the anterior, you know okay you've gone far down enough. هلا بالنسبة للleft side usually الناس بيطلعوا هون. شوف انت في عندك left main bronchus سهل. بعد هيك في عندك left upper lobe bronchus. عندك الابيكوبوستيريور. A lot of people would go and contour this. This is mistake. You need to stop here. Lingular bronchus, okay, it goes down. So usually you need to kind of expect it to be going down. And then you have your superior and inferior lingular segment. So you usually see them on the same slice or they just disappear. Okay, but they are usually down. So انتبه على هاي الشغلة. حكينا احنا التريك هي كمان مرة باللفت lower lobe. زي الرايت lower lobe you have to see the superior segment. شوف قد ايش superior segment عالي. وبعد هيك you need to see the medial and anterior segment, okay, before you actually stop. So this is another trick. هلا انا الكيس اللي اعطيتكم اياها اليوم نسبيا البي بي تي فيها مش كتير سهل الكونتور. يعني specifically so that you can learn. بس I'll show you a video which hopefully will open. And this video is just to show you the anatomy in a real case. Okay, so احنا هون يعني زي ما انتم شايفين احنا هون حاليا شايفين التراكية. We identify the carina on the coronal scan and then we go 2 centimeters above that. This is all PBT. So if we keep on going down, okay, so this is your right upper lobe. ومثل ما حكينا احنا بنشوف الابيكال والposterior والanterior بالright upper lobe. So we actually have seen that and we actually need to stop here. لأنه الابيكال طبعا راح تجيك vertical فمش راح يعني بالضبط هون النقطة اللي راح توقف عليها. اوكي لأنه هدول هم الposterior والanterior. هلا we keep on going down. Okay, this is bronchus. This is right middle lobe bronchus over here. So this is your right middle lobe bronchus. And then it gives you lateral and medial. So this is lateral and medial. So very clear because they're on the same slice. So you stop exactly here. هلا بعد هيك بصفي عندك هاي احنا we're going to go down to the right lower lobe. انتبه شوف شو لازم تشوف. لازم تشوف السوبيريور segment. هاي السوبيريور segment. Okay, it's very high up. So the superior segment has come off. Okay, this is the medial. It has come off. So you don't stop. احنا لسه we're going down. All of this is right lower lobe. So again, this is superior segment. This is medial. Okay, now it's a little bit not clear. Okay, this should be anterior, and then actually your bifurcation is here. So the slice before that is below that is the bifurcation. So this is the trick when it comes to the right side. I want you to think about this when you're contouring now. هلا بالنسبة لللeft side زي ما حكينا شوف انت عندك هون هلا if you go down pretty much you don't see anything. So حقيقة الابيكوبوستيريور has come off already. You don't keep on contouring up. هذا هون التريك المهم. اللينجولار برونكس سهل جدا انك تشوفه، اوكي؟ لانه زي ما حكينا انه it gives usually on the same slice and it's usually down. واحنا هيك هذا ماشيين صحيح. اوكي؟ هلا احنا we're going down again. Okay, here what you need to see is the superior segment, which probably is this one coming off. But you continue your contour and you need to see your medial and anterior. Usually it's a little bit difficult. This is the anterior. So you don't stop. You continue to contour this structure till it bifurcates. Okay, الميديال ما مبين هون بهاي الكيس. So I just want you to put this into practice when you do the case for today. وآخر شيء رح نحكي عنه بسرعة هو البريكال plexus. Okay. هلا البريكال plexus we want to contour from C4 C5 interspace down to the T1 T2 interspace. واحنا مبدأنا هون انه احنا we follow the scalene muscles. اوكي بدنا نطلع على الانتيريور وميدل سكالين وبالسكشنز اللي بيكون فيها الانتيريور وميدل سكالين مبينين وفي عندنا الاكزيت فورامينا مبين بناخذ من الاكزيت فورامينا لحد ما بين الانتيريور والميدل سكالين. اوكي وبالسكشنز اللي مش مبينين فيهم we just take between the muscles. We end the contour when the second rib crosses the subclavian neurovascular bundle. هلا هون شوفوا هاي هون الانتيريور scalene muscle. This is the middle scalene muscle and then this is the contour. Again, the best way to identify the cervical spine is to look at the sagittal window. So you look at the sagittal window, you see number 2 and then you count down and you start in the correct level. And again, bear in mind the anterior and middle scalene, they go into and insert into the rib. So your anterior scalene goes into the inner border of the rib while the middle scalene goes into the upper surface of the rib. وزي ما حكينا لما يكون في عندك السلايدز اللي هم مبين عندك الاكزيت فورامينا you contour from the exit foramina to that level between the muscles. هلا لما تنزل لتحت you usually see a structure which is vein anterior, artery in the middle, and then nerve, the brachial plexus is usually posterior. We continue to contour till the second rib, which is probably this one, till it crosses this structure. But if you still see the nerve or what seems like the nerve, continue to contour. So don't necessarily abide blindly by anatomy. Well, your structure should be between the clavicle and the first rib, so it should be in this area here. So always look at the coronal and make sure that you're in the right area. Again, arm position makes a lot of difference. Ideally, if you have the ability to do an MRI scan, that would be great, but not a lot of people have that ability. If the tumor is in a very cranial position, that might be limited by those to brachial plexus. If you're doing SBRT, for example, I'd always use IV contrast. I don't know, Dr. Ming, what is your practice with regards to IV contrast? You always use it. Okay. Whenever we do, I remember the first time that I did a contouring workshop and we had brachial plexus contouring, it was like everybody was all over the place. So again, it's okay to be a little bit unsure. IV contrast really helps if you do that. Knowledge of the anatomy is very helpful. slice thickness of not more than 3 millimeters also helps. And obviously peer review, like what we've seen today, is super helpful. So I would be also quite, I would be tempted to know if we have very good agreement today between the author contours and your contours when it comes to brachial plexus or PBT. So what I want you to do is perhaps maybe the first group over here to contour the PBT. The group in the back, maybe if you can contour the esophagus, and Dr. Suha's group if you can do the brachial plexus. And we'll give you maybe 15 minutes. So after you're done, just submit the cases, please. Yes, please.
There is a trend in the last few years of using artificial intelligence algorithm for OER's elimination. Do you rely on that?
So in my institution, I don't. We've not used it, to tell you the truth. It is, I think, super helpful in some tumors, in some anatomical regions, and for some organs at risk, but not that helpful in others. A lot of the vendors would tell you that, you know, their solution is the best and it helps a lot and it helps in every single case, but when you actually implement it in real life, it doesn't always materialize. I don't know, Dr. Umesh or Dr. Ming, do you use any artificial intelligence in your institution or these fancy softwares for contour? Yeah. No. Yeah. Dr. Umesh?
We have done it for head and neck oropharynx,
Okay.
trying to set up protocols for different sites, but it's still.
So the other thing is, which is very close to this, is we've trained one of our radiographers, so who's a person that was initially delivering the treatment on the LINAC, but then started doing more of the planning aspects of things. We've trained that person to do a lot of the organ at risk herself, and by doing that, actually, what she ended up giving us feedback is that a lot of different doctors, a lot of different consultants do the organs at risk differently. So because of that training for that lady, we kind of converged a little bit on how to do the organs at risk. So one way of potentially utilizing non-consultant, non-physician time is to train other people to do it, potentially planners, with peer review, obviously, and, you know, with feedback.
Actually, I made it in breast cancer, and we found that the error was about between 4 and 6% between the two, the manual or the conventional
Okay.
elimination technique and the artificial intelligence.
And this is for what organs? So
For breast cancer,
for
for
all
the
of
tumor itself.
for the tumor.
Yeah.
Okay. For the like tumor bed, you mean, or for the whole breast?
No, for the tumor bed.
For the tumor bed. Okay. Interesting. And what type of artificial intelligence solution did you use?
We don't use any commercial algorithm, but we use our own algorithm.
An in-house developed
Yeah.
one. Okay. Mika, I'm not sure. Are they allowed to submit again? Okay.